Good evening, everybody, and welcome to this Stride Workshop, part of Positively Staying In Together programme. Thembi Nkambule is an HIV activist from Eswatini, formerly known as Swaziland. She lived with HIV and an antiretroviral treatment for over 18 years. A mother of three, it was a ferocious desire to see her children grow that made her fight to live longer, and she's since dedicated her life to helping people with HIV. She also works as a consultant, program specialist and advisor. Thembi also holds a Bachelor of Arts degree in Humanities, a postgrad in Education, and various certificates in Management and Programming. She's worked as a teacher, training manager, and national director for the Swaziland National Network of People Living with HIV. In this role, she managed to help strengthen support groups through peer support and treatment literacy, and integrating this into their care programs to empower people living with HIV. Her belief that they should participate actively in their own care and treatment led to the rollout of what is called the Expert Client Programme, both at facilities and within communities throughout the nation. She's addressed various national and international forums advocating for improved quality of life for people living with HIV. And she's with us this evening to talk about her life, her work, and her own journey, which led us to us today. Thembi, welcome. We're really thrilled to have you with us.
Thank you very much. Thank you for the warm welcome, and I'm very much pleased to be with you today.
So Thembi, you were born in 1974 when the world was a very different place. What was it like for you growing up as a child in Swaziland or Eswatini?
I grew up in a mission. I was brought up by my grandparents, my grandmother and my grandfather. From the age of, I was told I was brought to them at 6 months. So I'm a grandparent's child. It was just a decision that the family agreed on. And I grew up in it was kind of a rural community, but it was sort of like a mission where there was a clinic, a school, and the church. So my grandfather was the pastor in the church, and my grandmother was the nurse in the clinic. So you can imagine being brought up by a pastor and a nurse at the same time. And yes, I would say it was quite a sort of a rural kind of environment. But the way we were brought up was cushioned by the fact that we were in that environment of a mission kind of, and I was not exposed to most of the technology of that time, but at the same time I was exposed to a loving environment that taught me that even in your family you would grow up with people that you never knew why they were there, and they had a different surname, and you were told, no, you are not related, and you kept on asking yourself, why so and so? And as they grew, they would leave the family, and you'd have new people coming in. So in a way, I grew up in an environment that kind of like taught us to care for other people, for the less privileged, an environment that whereby people who were sick would be cared for. I remember in some stages when I was growing up, my grandmother waking up at night to attend people who were very, very, very sick. And at times when she would even argue that, it's at night, I can't come out. She wasn't even sure whether it's people who were there or who were there because they were sick or thugs. And sometimes she would have to shout and check if they were really there for help. So that's the kind of environment I grew up in a very Christian environment, at the same time an environment that was kind of like caring for the sick and the less privileged. That's how I would sum up my growing up.
So when did you receive your own diagnosis? And can you tell us what the experience was like for you personally, and also for all the women in the same position as you at that time?
I usually start by saying I got sick around 2002. I had actually changed jobs, and I think I got into a challenging environment. And when I got into this environment, I was not used to, working late and stuff. So when I left, and I just left my teaching job, so it kind of became like a very huge challenge for me, because I had to change from being a teacher into a training manager. So it was kind of like tough. And I also had to change places where I was staying and move to another town, which was a bit colder. So I think one of the things that I started off very sick. I became very sick, and I thought it was flu, which was later diagnosed to be pneumonia. And then the doctor said, if it was pneumonia, the kind of medications that we've given you after 4 weeks, I think, of treatment, he just said, no, it cannot be pneumonia. Then we need to do further diagnosis. And then they did further diagnosis, and they said it was TB. So I started taking my TB medications, and though I could feel that the TB was, the coughing and everything was getting a bit better, but my body was not becoming strong. So late in 2002, I think it was around November, I then decided, because now I was, after leaving my teaching job, the place where I was a training manager was for an HIV and AIDS prevention program. So for in-school youth. So I now had information around HIV. So I decided, why not? Let me just go for a test. If I am HIV positive, then possibly it would be much better to know. And then we had no access to treatment, we had no access to antiretroviral therapy. But then I decided to go there. I said, since I'm not getting better, and it looks like I'm not dying, so I may be lucky if I know my HIV status. Maybe I'd find ways to boost my immunity or anything. So when I went for my HIV test that November, I found out I was positive. And luckily, the doctor just looked at me and said, you know what, there is treatment now, but you have to dig deep into your pocket. It was, if I think of it in dollars, maybe I would say around $50 at that time.
Per month?
So yes, per month, a month supply. So I looked, and I thought about it. I said to her, anyway, just give me the prescription so that I go and buy from the pharmacy that she had suggested. And then I stayed with that. I had that prescription with me for a whole month, because I was trying to decide whether to find information around this treatment, because I had not heard much about ARVs. So when I spoke to other people living with HIV who were actually in organized support groups, they actually told me that, this treatment will kill you, people are dying, there's when you take this treatment, it affects your liver and you die. And I just couldn't, I wasn't sure whether I had to take it. So I went online, I read some articles about it, and then I decided to start the treatment around January. I asked my aunt to accompany me to buy the treatment. No, let me just rewind a bit back. Then we had a funeral at home. One of our family members had died, and one of my aunts noted that I had been sick for some time, and then she came to me and said, have you done your HIV test? I just said, yes, I've done it. When somebody approaches you in private, it's even much easier. It's easier to to answer truthfully. So I just told her, yes, I've done my test. Then she says, what did they say? I told them about the medication that had been prescribed. Then she asked why I had not taken the treatment. I said, you know what, I'm still trying to find information, because I'm told if I start this thing, I have to take it as long as I live. And then she said, no, take your time, but in the next 2 weeks, I'll come back to you so that we go and buy this treatment if you are convinced that it would work. She also did her own research. Then one day she just called and said, it's 2 weeks now. What have you decided? I said, I'm taking the treatment. But then I'm worried, I'm a bit worried about the cost, because my job then did not allow for me to pay my rent and also buy the treatment and also have my kids at school.
So as a teacher, Thembi?
What?
Your role at the time was a teacher, is that correct?
Yes. Because even though I had moved from teaching then, but my salary was still the same as that of being a teacher, because I was kind of like still within a government, within the same ministry, yes, Ministry of Education. So I was getting the same salary. So I thought, no, I would not afford. But then my aunt convinced me that I will afford. So I bought the medication, and then within like, because my CD4 count then was like at 18, was 18. So after 2 weeks, I went back for tests, and I was told I was much better. I was feeling physically, I was feeling much better. And yes, I was, even at work, I was improving, and I was getting back to my old self. So when I went back to do my test after 2 weeks, I was told my CD4 count was now at 400 and something, which was a really great improvement. And I then convinced myself that, you know what, I will live. And I then started, when you go on over the media every day, there was something they were covering the issues of side effects and everything. So when I got better, I said to myself, you know what, I will go public about this, especially because around that time when I was recovering, I lost my elder sister, because for her, she was actually listening to this whole thing about the treatment not being being very dangerous, and unfortunately we lost her. And we lost her. So I said to myself, if I lose my sister, then it means how many people out there are dying, So I told myself I'm willing to help other people and to work with other people to ensure that they access, but one thing that I learned through my whole process was that for a person to start treatment, the ART treatment, people must have information, and the right information about whatever they're getting themselves to. So I learned that it shouldn't be taken as an emergency, but people must have informed decisions whenever they want to start taking the treatment. So which is why I also started programs around treatment literacy, ensuring that people would know what they're getting themselves into.
So Thembi, excuse me, you were recently featured in a BBC article, which is when you sort of came into my universe, and the article spoke of helping others to have what they called a happy death. Can you tell us, what does this mean, and what does your work involve? And can you give us an idea of how many people you've supported doing this?
The work around, I would not say a happy death, but a good death, when we talk about a good death, we are talking about, because we all live a life where we do a lot of things, and sometimes, you know, HIV would make people sick for some time. Some would be sick for a year, some would be sick for 2 years, and during that period when the person is sick, a lot happens, and which will involve personal, you know, your where you rewind, where you rewind, and you get time to look back at your life. And some would then begin to judge themselves, and they would begin to think that maybe they have done a lot of wrong, and even the people around them would start doing would stigmatize and discriminate. Some would be kind of lonely and would really need to have someone to talk to about their about their situation. So my work involved talking to people who are in their sick beds and giving them hope, and also explaining to them that, you know what, because most of the people in our country, it's heterosexual kind of transmission. It's not, so people would start thinking, maybe I did wrong, I slept with a lot of guys, I did such and such a thing. And you would get to a point whereby you would have to reassure this person that, you know what, whatever you did, hello, am I still on?
Yes.
Okay, so people would start blaming themselves, you know, self-blame, and thinking that whatever they could have improved, they could have done things in another way. And then being there for that person would actually help them to resolve such issues, you know, to realize that, you know what, I got HIV not because I was reckless, not because I had done anything wrong. It's just that you walked in the path where there was HIV, and you cannot really blame yourself for that. And there are people who have gone the same route. Luckily for them, who had a lot of partners, but luckily for them, they didn't go in their path. There was no HIV. And you'd have to explain, you'd have to bring out the good things that they have done. And you know, once they start thinking about the good things, they would be happy about their lives. And though for those who would eventually get to that place, they would have what we call a good death, because they would die not blaming themselves. And some of them would not even need anyone to hold their hand, because they are assured that, you know, they've lived a good life. And one of the things that I realized whilst doing this kind of work was that if the person dies kind of like blaming themselves, they would also leave a bitter taste with their relatives, especially those they leave behind. Some would start thinking, maybe we could have taken this person to this place, it would have worked, because they would also, when they see someone sick, some people just run away. But if they see that the person is well, is also kind of happy and walking the journey towards their end of life, you know, they also walk with them, and they leave kind of no regrets. So if you leave people regretting, they also you leave them in a state where they are also safe blaming the family. And in some cases, you find that people even start to fight, because you leave a lot of fights behind. But the issue, because someone was even saying to us, it's not about a good death. Then we say, you know, a good death is also ensuring that those you leave behind are kind of like happy, and they know that you are at a resting place. And also what we would do, it would be also to assist this person to say, because when there was no treatment, when there was not much access to treatment, people could not afford to buy it. So you would know that your diagnosis means what, you die anytime soon. So we would also assist them to write their kind of like small wills and what they would want to, what they would wish to see when they've left there, they're gone. So that would kind of like make them to be at peace, because a lot of people would worry about their children's welfare, would worry about the wealth that they've amassed. But if they feel that there is no need, they accept their fate, you know, it's kind of, you even see that, look at the person and you see that they are at peace. You see that the family is also at peace. They look forward to burying their, they look forward to having a dignified funeral for their loved one. And they also look forward, they know what to do once the person has died.
Oh, the old classic on mute. I do apologise. So, Thembi, you've worked in caring for the dying for nearly 20 years. And over that time, we've seen a remarkable improvement in treatment. Can you tell us what were the challenges that you and your clients faced then? And what are the challenges that you and your peers face today?
Okay. I think I've already talked about the cost. And then I think one of the other issues then was also the issue of, there was the issue of centralization. Even when government introduced the antiretrovirals free, but there was the challenge of the fact that it was still centralized. It was available in hospitals, in big hospitals, and people had to travel long distances to access treatment. And they would get there maybe late, and there would be queues and in those hospitals. So for some, they would just leave and go back home and tell you that, you know, I couldn't. By the time I was to be attended, I realized that I had to rush back because the last bus would be leaving by 1. So they would not sit there and wait to be treated. So they would just go back. So that was one of the huge challenge that people faced then. And then secondly, there was the issue of stigma and discrimination, you know, because when you got to the hospital, there was a section that was kind of like dealing with people living with HIV, people who were now on ART. And then people, when they see you go in there, we didn't even have to ask whether you were positive or not. We just knew that you were, oh, so and so is now on treatment, so and so is now on HIV treatment. So basically, it made people to move from the hospital closer to them to another hospital very far, so that they would not be seen by their relatives or neighbors going into those treatment areas. So which meant that now there was now a cost attached to your treatment, because there was now the traveling costs, though government had introduced this kind of service where people were getting the treatment free. And however, though treatment was now available in government facilities, there was still that kind of information that people were still dying. You know, these things were dangerous to the liver. It was especially the liver. But then we tried to counteract that with information that, you know, you have to do your tests so that whatever liver cirrhosis, whatever liver, if there are any liver, you are developing liver disease, whatever it is, liver, affects your liver, it's detected very early. So we encouraged people to do the tests and ensure that, you know, on a regular basis. And as more people realized that they were getting better, a lot of people started enrolling in treatment. And yeah, it's as more people were getting healthier, you know, people started taking treatment. And I don't think at the moment people are afraid of taking treatment, but I think what I would say, because for everyone, if you go to a hospital, you are offered an HIV test. So it's becoming kind of like a normal care program. But I am aware of some people who are still afraid of being seen to be taking the ART, the ARVs, and it's one in 1,000 people that still die of HIV related illnesses. But it still hurts when you see that the person refused to be tested, and they refuse to be treated because they are afraid of being seen to be taking treatment. In actual fact, with one of my clients, you know, I was talking to this woman for some time, and I'd been engaged by the husband. And then one day I was the lady had called, and then I said, okay, let's meet somewhere, because I didn't have time to go to her place. So the thing was that she said, you know what, my husband doesn't want me to be seen with people like you, because if I'm seen with you, people will think I have HIV. And then I said to her, can't we even meet to talk about cornflakes, you know, because this will be in a shopping mall and we'll be talking about cornflakes. She says, no. And then I realized that the stigma was now it was stigma. She thought that she would have she would experience stigma by associating with me. And at the same time, the stigma was now self-stigma, because she was stigmatizing herself. Because talking to me, I'm a normal human being. I talk about other things. I talk about a lot of other things. I'm human. But, you know, she made me feel so small. But anyway, these are things that you experience day in, day out in our work, where you also realize that, you know, as you do your work, some would still expect privacy to be given privacy.
You mentioned just now that your work is sometimes at a government level in your home nation. Can you tell us what contribution you've made to change in HIV care and policy in Swaziland?
Because I was now working, I then became the director of the national network. What we would do would also be to talk to people living with HIV in their communities, and then we would bring their experiences onto the table to inform policy. Because if you'd expect to do your advocacy using your own personal experience, in some cases they would not believe you. They would think you are making up stories. So what we would do would be to collect the stories, whatever we experience, whatever we hear from the communities, and we would sit as community people, and in most cases would even remove I would remove my professionalism to be, to be the community, so that you are kind of felt that you know what you are talking about, you've experienced, you have either experienced or seen it. So I think as I grew in HIV advocacy, I learned a lot about doing informed advocacy. If you can get a picture. If you can, you just get that story in recording. So if ever they say you are telling lies and then you start playing, you say, what is this? So, you know, those kind of stories, those kind of experiences being brought into the table did a lot of, helped a lot in ensuring that we ensure that whatever policy is brought in is influenced by, it's a policy by the people, and it would be for the people, so that the policy is not implemented, because a policy that is not informed by experiences would not actually work for the people. So it has to address the needs of the people. So basically it would be just bringing that community voice into the table, where definitely you are sitting with scientists, you are sitting with doctors, you are sitting with policymakers who have nothing to do with living with HIV, who have no experience of it, who don't know what your needs are.
When we last spoke, Thembi, you talked about your participation in International Women's Day, and we touched on some trans issues that people are experiencing in Swaziland. Can you tell us what your involvement was with this and why women's rights are important to you and your sisters in Swaziland?
Oh, yeah, women's rights. I'm a woman myself, and most of the experiences that women go through are things that you've either gone through yourself, or you are yet to experience, or you've seen someone very close to you experiencing. So basically, I am a member of the international community of women living with HIV in my country. And on Women's Day, I was actually asked by the international community of women living with HIV in Southern Africa, which is an organization that is made of women from 9 countries in Southern Africa. So basically on Women's Day, we were celebrating ourselves as women living with HIV for being resilient, you know, all these years, for being alive. We were actually excited that, you know, we are alive, and we are still looking forward to being alive. And so some of the women were still sharing the challenges that they still face as women. And one of the things that they share was the issue that we are still living in a very much patriarchal society, a society whereby you would believe and think that the policies and the laws that are there would protect you as a woman, but they are there on paper. They are not being implemented, and it becomes even hard for you to report whether you even know that the law has been broken. But it becomes very hard for you because you still rely on your partner or your husband for your sustenance, even for your food, your basic needs like food, your treatment, because we can't lie, our treatment has become is part of our basic needs. And they went on to share about, I think we had one trans woman who actually shared that their issues are not being discussed in the HIV arena, yet they are being raped because people want to correct them, you know, that corrective rape where people think they would rape and then you would be corrected, you'd become a man again, something like that. And their sexuality is not discussed at all, even within the women kind of networks. They are neither recognized as men and they're neither recognized as women, because women would say they would not talk about them, but we would talk about women with wombs, women who are straight, and they would not look at them as women, whilst also as men, they are not addressed as men. And I think one of the pledges that were made by the women who had gathered there was to ensure that we also, as we make programs for women, we should also know that we have trans women in our groups, whom we need to also now and again touch base with and find out what really are they experiencing. And I think lastly, I would say women also kind of like discuss the issue of funding, you know, the fact that funding was dwindling when it came to issues of HIV. Maybe it's because people think that by the presence of ARVs, now there was no need to also address the other social and economic aspects of HIV. It was now becoming more of a scientific issue, that whereby you just get your drugs, you go. Yet there are still other issues that would affect your sexuality, especially when it comes to childbearing, issues of childbearing. I think, yeah, basically that is what I would say about this event, the Women's Day event.
So, as the world is still reeling from COVID, I know that Swaziland is no exception to this. Can you tell us what impact COVID has had on HIV services in Swaziland, please?
Yeah, talking about COVID, I think we were most affected when, you know, there was this, what do they call it? When we started the lockdowns, they were calling it partial lockdown level something. I can't remember. Was it level 1, where it was tough to travel around the country, and yeah, people were made to. It was really tough because it was all being about flattening the curve and everything, but people had still had appointments in with their health services, where they had to go for tests, where they had to go for refills, and they couldn't act, they couldn't travel, and they were when traveling, they would be made to take out their appointment books. And you know, for HIV patients, we have a green book, so you would be made to take out your green book. You know, it's that point where everyone would see that this one has a green. If you really had with the hospital, it was kind of not so very nice. But with all the easing of the lockdown regulations, I think now it's even easier to move, and they tried to bring the medications to where the people are. I know that there are mobile clinics that go around, where they try to bring the ARVs, you know, community disbursements of ARVs. But I've heard a lot of people living with HIV, saying they cannot, it's not nice for them, because they would still prefer to go to hospital, because they are not known in their communities to be living with HIV. So they would still prefer to go to hospital. And another thing I think that people living with HIV are complaining about is that there's so much attention to COVID, such that when they get to hospitals now, they are checked. I don't know what is being checked at the gate, such that they find themselves being exposed to other people, knowing their status. You know, their status is kind of like declared at the gate, you know, as to why you are at the hospital, which they felt like it's one of those things. And with all the COVID lockdowns that we've had, Just last week, I was dealing with an issue of one woman who was saying, who just sent us we have a group, a WhatsApp group of women living with HIV, and she just flashed a message where she said she's thinking of stopping taking medication because she doesn't have food, and and this kind of medication has brought her appetite, and she really doesn't like it because she doesn't have food, you know. So I just said to her, please just let's talk on your inbox, and then we then had a conversation around it, and I didn't have much money, but I tried to give her money just to pushing her for that period whilst we look for assistance for her. But basically, it's been a very tough period. And what we've also heard is that people who are now taking some medication, I think it's second line medication, they've also been stopped and they've gone back to take dolutegravir. DTG is it's been replaced, and they're not sure why, but they suspect that it's because it was used in COVID treatment, which I am not sure if it was like that, but some are happy to be back in what they call the first line regimen, but some are quite not happy because they believe that they were now in the second regimen. And they say the explanation that they kind of get from hospital is not convincing, from the nurses is not convincing for them that they are now back on first line, you know, on the first line regimen. But I just hope, we keep on reassuring people that, you know, you must keep on getting your test, you must do your viral load and be sure that you are still virally suppressed. And we have not had a case of someone who had a problem. Most of them are still kind of like virally suppressed. So basically, maybe it has worked, but I think one of the things that they really complained about was the fact that it is not well explained, you know, by the healthcare workers why they've been changed. They're being changed.
Thembi, we're almost out of time, but for one last question, please. Can you share with us any sort of cases that you remember which are special to you?
One special case, I would talk about one special case where I just recovered, you know, and I wanted to see everyone recovering from being sick. And, you know, I could see that this lady was very sick, and I tried talking to her. I tried giving her hope. I tried telling her my own story, and she said, you know what, if I don't want to do the HIV test, but I'm willing to take the drugs. And I said, but you cannot take the drugs without treatment. But she insisted that she didn't want to be treated. She wanted to be treated without being tested. And eventually she died. And one thing that she had shared was also her willingness to see her children grow. And but she just couldn't take the test. So it made me feel really bad, you know, because I still feel I could hear her love for her children, but her fear for being tested stopped her from being there for her children. And another case that I would talk about is also the death of one of our activists, of our community activists, whom just one day we just woke up and we were told she had just died. And we still ask ourselves what went wrong with her, whether she had other ailments or anything, because then I think everyone would just check you for all your other HIV stuff and not check the other non-communicable diseases. it was really painful for me because I had just spoken to her, and next thing she died. And when she died, we were told that she had actually, the postmortem said it was hypertension. So the issue was, as we were getting better, we know that one of the side effects would be your fat, whatever your fatty thing, you'd become fat and stuff, but we're not taking care of the other things. We just kind of like concentrated on ensuring that we live.
Thembi Nkambule, we're out of time. Thank you so much for a fascinating talk on the invaluable work that you do. Thank you from our community for looking after so many of us, and there's plenty of love for you coming from me today.
And one last one, Greg. That lady, that girl on my Facebook page, I saw that you liked it. That's my last born daughter. So you see how much they've grown.
Oh yeah, fantastic.
Yes, I just wanted you to know that that was my last born daughter. And when I was diagnosed, she was kind of like 4 years now, she's 26.
Wow, Joe, good job, well done. Natural Earth Mother. Thembi, that was great.